Good morning, everybody. Many thanks to everyone for joining us for this important conversation on the intersection between HIV and Mpox. The initially slow and inadequate US government response to the Mpox crisis in May and June of last year led many advocates, including former PrEP for All Managing Director James Krellenstein, to call on the Biden administration to do more. Ultimately, the government response, including expanded testing capacity, accelerated vaccine access, and reduced barriers to TPOXX, was driven significantly by HIV/AIDS and queer advocates' demands. Thanks to that work, we have seen great success as new diagnoses have dramatically decreased. This is a more positive way in which these infectious disease crises have shown similarities. Impassioned, informed action from affected communities has been a necessary component to prompt a comprehensive and effective response. Unfortunately, HIV and Mpox have also overlapped in a darker way for our communities. Around 40% of those diagnosed with Mpox in the US have also had HIV. Those of us living with the virus have also been far more likely to suffer from severe manifestations of Mpox, particularly when we are not on HIV treatment. With nearly half of people living with HIV not on treatment in the US, and a quarter of people with HIV not on treatment worldwide, that is unfortunately a common circumstance, particularly as our broken healthcare system and government response fails communities of color. I should have introduced myself. My name is Jeremiah Johnson. I'm the Acting Executive Director of PrEP for All, and we're incredibly grateful to partner with the New York City Pandemic Response and for all of these great speakers here today as we discuss the important considerations for communities affected by both HIV and Mpox, and to hear more from Dr. Al-Sadr, Dr. Wong, and Dr. Nelson. Thank you so much.
Well, thank you very much, Jeremiah, for this very important introduction and framing. And I'm Wafa Al-Sadr. I'm the director of ICAP at Columbia University and executive vice president for Columbia Global. And I'm also one of the leads for the New York City Pandemic Response Institute, an institution that's set up to really try to find ways to be better prepared to deal with major health threats that our city and our country and the world may face and will face in the future. I'd like to take a few minutes to introduce our speakers for today. We're very fortunate to have two remarkable speakers that will focus on the intersection between Mpox and HIV. Our first speaker will be Dr. Marsha Wong, and she is a physician with training in both internal medicine and pediatrics, and also training in infectious disease as well. She is currently a medical epidemiologist at the New York City Department of Health and Mental Hygiene, and where she provides her experience and her expertise in HIV and sexually transmitted infections. And also most recently, she was working on the 2022 Mpox outbreak as a clinical and treatment subject matter expert. Welcome, Marsha, to this webinar. I also would like to introduce our second speaker, Dr. LaRon Nelson. And Dr. Nelson is the Independence Foundation Professor and Associate Dean for Global Affairs and Planetary Health at the Yale School of Nursing. He also serves as the director of the Justice, Community Capacity, and Equity Core in the Center for Interdisciplinary Research in AIDS at the Yale School of Public Health. He is a family nurse practitioner with over 20 years of clinical public health practice experience and almost 20 years involved in health disparity research. I encourage all of the individuals who are attending this webinar to please do share your questions, and you can use the chat function, and we will be then, after the presentation, we'll have the opportunity to take some of your questions and discuss them with our speakers today. So without further ado, I'm going to hand this over to Marsha to give us her presentation first. Thank you.
Great, thank you. Let me go ahead and try to share my screen here. Okay, can you just confirm that I am seeing this in, that you're seeing the slide?
Yes, but it's in
presentation.
In the presenter mode, not
okay,
in.
Hold on. Okay, how's that?
Now it's great. Thank you.
Okay, great. Yeah, so thanks so much for the opportunity to present today. I was asked to share about our experience here in New York City with severe Mpox manifestations in people with advanced HIV. The information today is presented on our current knowledge as of today and is subject to change. So I have nothing to disclose. So basically, I'm going to review some epidemiology, but mainly wanted to get to the management of severe Mpox disease and manifestations that we've been seeing in New York City. So Mpox, formerly known as monkeypox, is an uncommon zoonotic disease caused by a virus from the orthopox virus family. Since May 2022, there's been Mpox transmission spread primarily through sex and intimate contact among social networks of men who have sex with men, transgender, gender non-conforming, and non-binary people. I think it's worth noting that it's been a neglected disease, and areas historically reporting cases in Central and Western Africa have received few resources related to vaccine treatment and or support in scientific advancement, despite decades of case reports and transmission. So here's the epidemiologic curve for the United States, with the number of Mpox cases here on the y-axis over time on the x-axis. While we're past the outbreak, we're still seeing a low level of cases nationally. And here's the distribution of cases across the United States with 32 deaths reported as of mid-February. So starting at the end of August, we started seeing our first Mpox patient that was started on VIGIV, and I'll explain what that is in a little bit. And subsequently, we started seeing an increase in call volume for help with the management of severe manifestations of Mpox coming in from providers here in New York City, which mirrored the call volume to the CDC clinical consult line. So even though the epidemiologic curve at that time was on its way down, we started seeing increasing reports of severe manifestations. And this prompted the CDC to put out a health alert at the end of September, specifically about severe manifestations, particularly among people immunocompromised with HIV. CDC published their experience with the first 57 severe Mpox cases in MMWR. 82% were in people living with HIV, mostly Black, non-Hispanic men, with a significant percent experiencing homelessness. Of those who had CD4 data, more than 70% had a CD4 less than 50, and 21% of patients died. Last week, there was a global case series published in the Lancet of almost 400 cases of Mpox in people with HIV with a CD4 less than 350. They reported the most common organ complications described were skin, secondary bacterial infections, and lung manifestations. So hospitalization in this group was really high. Almost 20% of patients required hospitalization in the general wards, almost 10% in the ICU, with an overall mortality of 7%. But when you look at those with CD4 less than 100, you can see that around 30% required ICU level hospitalization, and almost 30% died. This study concluded that with greatest disease severity, that the greatest disease severity and hospitalization and death were those with low CD4 and high viral loads. A recent abstract at the recent conference on retroviruses and opportunistic infections, or CROI, concluded that high viral loads also seem to be associated with a greater risk of severe manifestations. And sorry, I forgot to mention, you can see that this really drops off significantly with much lower ICU and death when the CD4 is above 100. So there's no FDA-approved medication for the treatment of Mpox, but tecovirimat is our first-line medication for Mpox under a CDC Expanded Access Investigational New Drug Protocol. It's usually given for 2 weeks. Here in New York City, we had 11 severe cases among people with HIV who required a prolonged treatment course of tecovirimat. And these were collected through the CDC's clinical consults or from providers calling the New York City Health Department. These are mostly young, Black, non-Hispanic men living with advanced HIV, many of whom were living in unstable housing in the previous year, and all of them were hospitalized for severe Mpox disease. All had a CD4 less than 200, and most had a CD4 less than 50 with high viral loads, and were not on antiretrovirals at time of Mpox diagnosis. And while some had received one dose of the Jynneos vaccine, which is the vaccine we're using for Mpox, all of them had been diagnosed with Mpox within 5 days of receiving the vaccine, and so would not have had any immunity and may represent difficulty either accessing the vaccine or delayed presentation to care for the vaccine. So now I want to review management of severe Mpox disease based largely on our experience, since there's no FDA-approved treatments for Mpox and very little data to inform care of these patients. The two biggest takeaways is immediate start of tecovirimat and antiretrovirals. If Mpox is suspected, start tecovirimat immediately. If the CD4 is less than 200, you have a new diagnosis of HIV or you do not know the CD4 count. Do not wait for results to come back before starting Mpox treatment. These patients need close monitoring if they're being managed as outpatients, and it's also important to immediately start or restart antiretrovirals. So the reason why antiretrovirals are important is because tecovirimat is virustatic, meaning that it suppresses Mpox, but it's not virucidal, meaning that it does not kill it. Because of this, we found that Mpox will persist until the immune system has reconstituted, meaning that you need recovery of the immune system. Any Mpox treatments given suppress the Mpox virus to buy time until the patient's immune system is able to function. So people with advanced HIV require extended Mpox treatment until lesions have healed and the patient has had immune reconstitution. This can take many, many months. Tecovirimat also has to be taken with the fatty meal. So if there are any concerns about absorption or the patient's ability to do this, we really want to have a low threshold to switch to intravenous tecovirimat. For hospitalized patients, we would consider a combination therapy, so IV tecovirimat or one or more of these treatments, as well as multidisciplinary consultation, such as infectious disease, dermatology, wound care for debridement, or ophthalmology. We also highly recommend calling the CDC clinical consult team. And I'm going to talk a little bit more about vaccinia immunoglobulin and brincidofovir, since people might be less familiar with these two treatments for Mpox. Okay, so now I'm going to briefly review some other options just to give you sort of a tour. So first I'm going to go over vaccinia immunoglobulin intravenous or VIGIV. And because Mpox is part of this family of viruses called orthopox viruses, which includes smallpox and vaccinia, VIGIV is actually approved for vaccinia virus, but there may be some cross-reactivity between Mpox, and it may be effective against Mpox, but although efficacy is really unknown. And our understanding of how to give VIGIV has really evolved since the outbreak started, and now we're much more aggressive with dosing than we were at the beginning of the outbreak. I've included dosing here if you need more details. So brincidofovir is the same medication as cidofovir, except it doesn't have the kidney toxicity that we normally see with cidofovir. So no adjustment is needed for kidney impairment, but people should be monitoring liver function, and it's given once a week. It's available for Mpox treatment through an emergency investigational new drug request through the FDA, and is distributed through this strategic national stockpile. Okay, so there are also a few providers who reported using topical cidofovir, meaning that the medication was applied to the skin, and intralesional cidofovir, meaning the medication was injected under the skin into the Mpox lesion. These strategies were used for suspected bone infections with Mpox, lesions involving cartilage, or other areas that are difficult for systemic Mpox treatment to reach. I've included the formulations here just for reference. So returning to our experience here in New York City, this slide describes the treatment used among people with HIV with severe disease. So median time from specimen collection to treatment initiation was 5.5 days. Duration of tecovirimat for everyone was beyond the usual 14-day course, which the lowest being 21 days and the highest being greater than 120 days as of January 31st. Unfortunately, we weren't able to collect the exact days of tecovirimat duration. Most received VIGIV, including multiple doses, and several patients received multiple therapies simultaneously, usually tecovirimat, VIGIV, and cidofovir or brincidofovir. In regards to clinical outcomes, all were hospitalized. And as of January 31st, 9 have been discharged or died with a median length of hospitalization of 57 days. For the 2 that remain hospitalized, length of hospitalization was 166 and 106 days. So we are seeing months and months of hospitalization for these patients with a really high mortality at 45%. And I will note that we had an additional patient pass away since the end of January, bringing the mortality to 54%. So I wanted to touch briefly on tecovirimat resistance. As of the end of November, there have been 2 documented cases of out of 4,000 specimens analyzed by the CDC. So both patients had been on prolonged courses of tecovirimat. Testing is performed by the CDC, but they are unable to return results to providers. So we would consider resistance if the patient improves and then stops improving or worsens while on tecovirimat. With this in mind, we'd really have a low threshold to consider switching to IV tecovirimat and adding additional Mpox treatments, as well as following the CDC clinical consult line. So now we're going to review some of the severe manifestations of Mpox that we've seen in New York City. I want to mention that some of the following slides include graphic images, so please do look away if it becomes disturbing, and they are quite graphic. Okay, so here are 2 examples of some of the facial lesions that become so extensive that they obliterate recognizable facial features. So on the left, just to orient you, this is the nose bridge, these are the eyes, and this is the forehead. And on the right, this is a cheek, a nose, and lips. Here are some similar lesions on the hand. This one's more extensive on the left, and then on the right, more circular and heaped up. A severe Mpox of the eyes has also been described. This is a series of CAT scans. Here in box A, you can see that both eyeballs, so to orient you, this is the front of the face, and these are essentially the eyeballs, or we call the orbits. And you can see here that they're still intact, but over time you can see this one eyeball sort of flattening. And then in box C, you can see that both of them have collapsed. Here are several more eye complications, including Mpox lesion over the eyelid and inflammation of the cornea. So the cornea is sort of the first part of your eye, and it's so severe that the eye doctors describe this as corneal melt. So you can see the progression here. So it's important to counsel patients to practice frequent hand washing, avoid touching their eyes, and stop using contact lenses to avoid directly infecting their eyes with Mpox. For lesions close to the eyes, you can also consider trifluoridine eye drops to prevent Mpox infection of the eye. We've also had several patients who've had uncontrollable large volume gastrointestinal bleeding, both from the esophagus and from rectal lesions. So there's a recent publication that also described intestinal ileus and obstruction, which is kind of like an intestinal paralysis where food can't be moved along like it's supposed to. So here is an example of esophageal Mpox lesions on autopsy. These were described as being nodular and bled easily. And also some of the rectal lesions at autopsy were described as deep ulcerations with extensive necrosis. So other severe manifestations that we've seen include severe facial, oral, and upper airway swelling that require the patient to be placed on a ventilator for airway protection. There's also the possibility of osteomyelitis or a bone infection, perhaps similar to what historically has been seen with smallpox infections. This has been raised, but so far it's really been unclear. There's also been at least one case of something called hemophagocytic lymphohistiocytosis, which is a syndrome where the immune system is excessively activated. And this was described as part of a CDC protocol. I highly recommend this webinar if you want to learn more about some of the severe manifestations. I also wanted to give you a few more details about the extensive thick black lesions, which I showed you on the previous slides. These are at high risk for secondary bacterial infections and may need antibiotics. We also would strongly consider debriding these lesions and doing topical or intralesional cidofovir. So on this slide, you can see before and after photos. So both of these got, this patient was on multiple Mpox treatments, and you can see the lesions really improved, especially with the intralesional and topical cidofovir. Okay, so moving forward, there's no further photographs. So if you looked away, you're welcome to look back. There's a lot of questions raised about the role of immune reconstitution inflammatory syndrome, or IRIS, in the Mpox disease process. And it's still unclear what role it plays. There were some patients reported in Texas that raised concern for IRIS. And in the multinational publication in the Lancet I mentioned earlier, IRIS was suspected in 35% of patients who reinitiated antiretrovirals. And among those, 57% died. However, it can be really difficult to make an IRIS diagnosis. And I think it may be difficult to differentiate between IRIS versus overwhelming disseminated Mpox disease. For the few patients in New York City who we were aware of autopsy results, findings did not seem more consistent with overwhelming disseminated Mpox rather than IRIS. And it did not seem that in our severe cases, IRIS was central to the disease process. However, our patients may have differed in that while all were restarted on ARVs, immune reconstitution was slow to non-existent, and there is a higher risk of having IRIS with a faster immune reconstitution. So steroids used to treat IRIS should be approached with caution, and in some of our cases it worsened disease, although we have heard anecdotally that in other cases it may have been beneficial. But regardless of concern for IRIS, do not stop antiretrovirals, since the patient will not be able to clear the Mpox virus without immune reconstitution, and may end up with disseminated overwhelming disease, Mpox disease, without antiretrovirals. And our Mpox treatments really are temporizing measures at best. So in conclusion, we've seen severe manifestations in those with advanced HIV. And these patients have really long, months-long clinical courses and experience prolonged treatment and hospitalizations. As the outbreak has evolved, we are seeing this endemic of Mpox and HIV among Black and Hispanic Latino people due to social factors that limit access to care and prevention from longstanding systemic inequities. So everyone being seen for Mpox needs to be tested for HIV, and for people with advanced HIV, immediately start tecovirimat and antiretrovirals. Antiretrovirals remain the most important treatment for Mpox, and you need to monitor and treat for bacterial superinfections. And this group of people with advanced HIV experienced really high social vulnerability, severe Mpox manifestations, and high mortality. Early and extended tecovirimat, along with other Mpox treatments, are important, and it really highlights the importance of social support services like care navigation, housing, to improve engagement and retention in HIV care. Okay, so a few resources. Just want to really quickly say thank you. There are so many who contributed to this presentation, particularly Dr. Mary Foote, and to the care of patients. I also want to just acknowledge the inspiring care, compassion, and strength of our New York City provider community, who really confronted a multitude of challenges, and the patients and their families who, even in the face of incredible suffering and death, still sought to contribute to our knowledge amidst the uncertainty of a re-emerging disease. Also want to acknowledge those of you who have been intimately involved in this outbreak response, to acknowledge the mental health toll it has taken, whether you are working with the affected communities in public health or caring for patients. So please take care of yourselves. And thanks so much for taking the time today.
Well, thank you very much, Dr. Wong. Very much appreciate your presentation. I think you set the stage beautifully for our next presentation by Dr. Nelson. So I'm going to hand it over to you, Laurent, and welcome. Thank you.
Thank you, Wafa, for the introduction. Thank you, Wafa, for the introduction. And I appreciate the invitation by the Prep for All and the New York City Pandemic Research Institute to talk to you today. So I'm going to talk about social and structural factors that undermine access to services. And this builds off of what you just learned from Dr. Wong's excellent presentation. First, I'll talk about what we learned from the American Men's Internet Survey. Acronym is AMIS. I think that's what most people call it. It's a cross-sectional, non-probability online survey of cisgender men who have sex with men in the US. And they did a recent analysis, maybe it was a sub-survey about monkeypox. And this was published recently in MMWR. So what they found is that overall vaccination for monkeypox was low. But it was lowest among Black MSM, with only 11.5% of their respondents having received the vaccination. I think the highest was close to 30%. That was among Hispanic men, but generally it was low. Nearly 1/3 of the men in that survey who were not vaccinated for monkeypox had actually attempted to get vaccinated for monkeypox. I think it was specifically 28.5%. And they also found that there was a higher percentage of individuals who were on PrEP who were also vaccinated for monkeypox compared to individuals who were not on PrEP. So if you were on PrEP, the percentage of those people on PrEP who had monkeypox vaccination was 31%, and among those who were not on PrEP, it was only 7%. So a big difference there. And this is important because some of the same factors that impede access to PrEP as a prevention strategy, I think, are also implicated in impeding access to monkeypox vaccine as a way to prevent severe disease. This is data taken from a study I was a part of years ago from the HIV Prevention Trials Network, 061. It was done in 6 cities. New York City was one of them, and this is data just from New York City. Across the top, you see economic, social, and legal hardships that we collected based on survey data: unemployment, recent job loss, financial crisis, having a history of recent incarceration or recent arrests, unstable housing or no health insurance. And then across the left-hand side are risk factors and STI incidents among the men in the sample. It was about 300 people. And so if we first start by looking at social hardships, what you see here is there was a high prevalence of people who had condomless insertive anal intercourse, condomless receptive anal intercourse, who also had social hardships. So if you look across the top at these numbers that are reaching 100%, these are Black MSM in New York City. So among those who reported condomless insertive anal intercourse, 77% were unemployed, 83% had a recent job loss, and 83% experienced a financial crisis. Extraordinarily high numbers. A bit lower, but more than half for people who reported condomless receptive anal intercourse. A little more than half were unemployed. About half had a recent job loss and experienced financial crisis. We know from that, from associations, that recent job loss was associated with condomless insertive anal intercourse, and having a recent financial crisis was associated with having 2 or more sex partners. All indications for things like PrEP and potential exposures to the monkeypox virus. If we move to legal hardships, this is history of incarceration and recent arrest. And I think recent arrest in the questionnaire was asked maybe about police detention. Were you detained by a police officer? So again, these are extraordinarily high. I think this was during the time in New York City where maybe stop and frisk was the policy. I think this was around the same time. But 82%, for example, reported having been recently arrested. 82%. I think this is to have been detained by a police officer. Folks who reported commonness insertive anal intercourse. For folks reporting receptive anal intercourse, recent arrest was down to 64%. And history incarceration among this sample, this cross-sectional sample in New York City was very high. And recent incarceration does not mean imprisonment in the state system, but it could mean being detained in jail. We also found that from that, having a recent conviction was associated with having any STI at 6 months. So increasing people's, in this situation, having an STI would be a risk factor for something like monkeypox exposure. And then in the situation of the social hardships, first was economic, then legal, then social. We looked at unstable housing and not having health insurance. And the pattern is the same, that you see that among folks who have indicators that put them as eligible candidates for something like PrEP or potential exposure to monkeypox, that high percentage of those people had social hardships, including unstable housing and not having access to health insurance. And then in that, unstable housing was also associated with having any STI at 12 months. And these are incident STIs, something that could have been cured and perhaps the one becoming reinfected. So even as we think about these hardships, which are, I think, responsible for a lot of inequities that we see across different pandemics, including the COVID pandemic, a question arises that I urge us to consider is, does the healthcare environment play a role in that? The places where people have to go for screening and monkeypox to receive the vaccination or to receive some assistance for treatment. And I think that it does play a role. Healthcare settings are not just occupational sites. They are social environments, and they can have a structural influence on monkeypox prevention. The climate that's created by the people who occupy these roles are structured into these health settings, and they can impact monkeypox outcomes. So this is an example from the PrEP literature. This was a study done by Sarah Calabrese, which looked at medical students and their prescribing practices for PrEP. And they found that medical students were less likely to offer PrEP for patients with the highest need. And that was related to partly to their moral evaluation of those individuals' sex practices. I will tell you, I visited my physician some months ago, and I asked about monkeypox vaccination. And he laughed. He wasn't mean, but it was this response. He laughed and he was like, come on, like, you don't need it. And I think he was he was looking at me and trying to reconcile why somebody who was dressed the way I was dressed, kind of like I'm dressed now, would need monkeypox vaccine. Why would I ask for that? But implicit in that was the image in his mind of who those people were who would be the candidates for monkeypox vaccine. And so this was very evident to me, even in this interaction with my provider. I'll come back to that story in just a moment. But also in Calabrese's study, they found that the medical students that they had in this experiment were more likely to rate Blacks as risky for condomless intercourse, and that what that did was translate into a decreased willingness to prescribe PrEP. They didn't want to be seen as sanctioning behavior that they did not approve of. And so again, this is an exercise of power that happens in a healthcare facility, and that actually regulates access to people, downward regulates access by making it more difficult to get, because you can't get through some of the providers' own views about who they think you are and what they think you should or shouldn't be doing, and what role they think offering you some prophylactic agent contributes to behavior that they don't approve of. And they also view these structural factors, some of what I described to you just a few moments ago around history of incarceration or financial crisis or losing a job or not having stable housing, as personal failures, as a proxy for whether or not these people are responsible because they can't keep housing and don't have insurance, or they were in jail for some reason. And so these are also very important structural issues that can happen in the healthcare setting. And also the manifestation of them is that you may not get treated the way you want to be treated, which could influence the degree to which you want to still be engaged in a healthcare practice with that facility, but also access to things that you may need to prevent things like monkeypox infection or get treatment. And so one of the things that we have thought about is ways in which practices can improve their work with patients. Patients in general, but also people of color and sexual minority individuals. And so there's really three areas that we've thought a lot about. One is how to promote autonomy, competence, and relatedness. This is based on self-determination theory. And these are sort of these three basic human needs that if in these environments, they can be supported, that they can be very helpful in making sure that folks can reach health goals, particularly if those goals are prevention oriented or adherent to some particular treatment plan. So autonomy first is the need to feel that you have control over your lives, that you're not pressed to do something you don't want to do. Relatedness is really the feeling like somebody that you're important people in that environment. And in the healthcare environment, that would be the people who are working there, who you're relying on for care, that they care about you beyond sort of the mechanics of providing care. And then competence is the need to feel effective in actually dealing with that environment. Can you get done what you need to get done to reach those goals? We published a paper on this recently, maybe a year ago, in Sexuality Research and Social Policy, in a way that we try to outline how this can work. And so the first part is using an integrative anti-racism lens, like helping people who compose this healthcare setting understand what it looks like to view their work through a lens of integrative anti-racism. And so that includes recognizing and disrupting interlocking systems of oppression that show up in their practice that they may not even know happens, identifying and addressing structural determinants, resisting practices that promote heteronormativity, challenging approaches that privilege whiteness over other cultural identity and racial identities, and then recognizing and supporting social cultural assets that sometimes can get read as deviant or not important, but helping them recognize those things as assets that should be promoted. And so this is specific to PrEP, but I think this approach can work for multiple health domains and practices, including Mpox. So maybe I'll say for a moment about the competence. The competence support is really important because a lot of what will impede access are things that do actually happen outside the clinic. And so it's helping providers figure out what role do we have in trying to intervene on issues that do not happen within the four walls of these clinics. First is recognizing that they can have a role and that they should have a role, and thinking about how to support clients to achieve those, to overcome those barriers. I'll walk you through just some examples of this. This is just a table, and it really tries to outline, to give examples, more concrete examples of how this might look in practice. So across the top are the components of self-determination theory, autonomy, competence, relatedness, and an integrative anti-racism lens is the final column. And then on the side, you see components of a particular strategy, which is comprehensive risk counseling and services, which I think still gets used in some places for HIV treatment, but also more recently for PrEP. So it involves needs assessments, behavioral counseling, developing an action plan. So you can see in this sort of magnified version of particular ways in which your approach to a patient can be autonomy supportive and take into account integrative anti-racism. So let's say for my example with my physician who laughed, right? So his laughter was a reaction to the possibility that I could be somebody who fit his image of who these people are who get monkeypox and who would need vaccinations. And so for him, it would be important to reflect on his emotional reaction to me, and to what degree would he have that same reaction if I was a white gay man or if I was a Black straight man. And so that is sort of an important way to think about it. If we go down to behavioral counseling, here's another example of how you can demonstrate relatedness is, inform the client that you would respect whatever decision they make, and supportive of them in an ongoing process about their life, not transactional based on will they do what you asked them to do and maybe take the monkeypox vaccine, but that regardless of what they did, you would respect that and you would support them. And then if a client is resistant to, if they don't want to do what you're asking them, think about what is happening from an anti-racism lens. Could it be a response to this harmful history of anti-Black, anti-LGBT experiences that they may have had in systems that are supposed to help them, right? That are actually doing things that may be harmful. And then also examine whether or not your therapeutic approach is actually reinforcing anti-Black and anti-gay violence by privileging ideas or solutions that center whiteness or center respectability or center heteronormativity. Another example in action planning, which is about how you can demonstrate relatedness, is that you can express respect for the client's action plans, to reassure them that the primary role is to support them and not evaluate their performance. And that inform them that this is a plan, it's not a contract, and that you want to meet again to reassess this plan. Because if patients feel like they have failed because they've not been, how would I say it? They've not followed through completely with the plan. But if they see the plan as a contract that they failed, they may be less likely to re-engage with you because they'd have to perhaps experience shame around that failure. And then just to remember that imposing any component of a plan among gay men, people with HIV, that is against their wishes is an exercise of power and dominance. We don't have to talk about this in healthcare settings, but that is what it is. And if you're inclined to override the client, reflect on ways in which that, consider ways in which that might reflect white supremacist and homophobic logics that may underlie how you justify your approach to working with them. And so we learned a lot from pandemics. You see here, I have the learn crossed out. So it's there, our pandemic lessons, we haven't always quite learned from them. But I think one is that healthcare settings can be a site where equity and pandemic responses can be undermined if we aren't sufficiently training and providing healthcare providers and workers with appropriate tools to promote equity. And I know New York State Health Department, for example, has worked on tools to help counteract those issues. Telehealth and community health workers can expand access to services, but also I think that people who are impacted by monkeypox disproportionately also have answers and ideas. And I think in COVID-19 pandemic, we learned that a lot of the key and most effective answers came from communities who are most impacted by it. The Amos survey that I described at the beginning of this talk was a survey that looked at what were gay men actually doing to enhance prevention efforts against monkeypox virus. So they had already been thinking about and organizing and doing things to protect themselves. I think we can learn from that and optimize those efforts that are happening locally among impacted groups. And then lastly, structural inequities that we discussed, large inequities can contribute to disproportionate exposure and burden, as we already know that, but also disproportionate limits on access to prevention and treatment. Thank you, and I look forward to the discussion portion.
Great. Well, thank you. Thank you very much, both to you, Laurent, and also thank you to Marsha as well. And I encourage our audience to please put in your questions in the chat box, and we'll use these questions to generate the conversation with our speakers today. I think maybe I'll start with a couple of questions, and maybe with you, Marsha. I think the severity and the gravity of and the implications of Mpox disease amongst people living with HIV certainly was quite evident from your presentation. The experience in New York City and the experiences in this country and around the world, which highlights to me the value of prevention and gets at the value, of course, of vaccination for people living with HIV. And I'm wondering, we heard also from Laurent that the utilization of this vaccine remains quite limited to certain populations at high risk. So I'm wondering from your perspective, from both of your perspective, maybe we'll start out with Marcia, is what can we do to be able to increase the coverage with this vaccine for the population that most at risk for severe disease?
Yeah, that's a great question. If we could do it, we would have what we're seeing now. I mean, I think in the early days it was a limited resource, and I think that really put a damper on the messaging, at least here in New York City, and I think across the nation as well. It's just such a limited resource, and of course, when you have a limited resource, it goes to those who are most privileged. And who have access for all the reasons that Dr. Nelson mentioned. So I think letting people know that there is access, but I think it has to be very relational, as Dr. Nelson was mentioning. In my practice, I've started many people on PrEP, and it's such like an intimate relationship to really bring, they see you for the first time and they're like, oh, there's just another person that's going to judge me. But I think, it takes like individual relationship. From a public health perspective, it may take some door knocking, messaging. But I think also from a sort of, if you're like a healthcare system level, look at your patient panels, who has been lost to follow-up, and really trying to get those people back in to get those CD4s, even just above 100. If you can get the CD4 above 100, if you can get them to like re-engage in care, if you can get them into housing, all of those things I think can be helpful. I think now is the time to be able to really vaccinate now that the epidemiologic curve is down. Now is the time to really vaccinate, just because, we do worry that if we still have this in our population come the summer, that there may be a resurgence and we may see it again. And so I think now is the time to really sort of build the groundwork to really get people in, get them vaccinated, and get them re-engaged in care.
Thank you. And Laurent, what about from your perspective? What can we do? What can we do better? In terms of closing this gap?
I agree with Dr. Wong's response about the relational processes that happen between the patient and provider. I think that's going to be important, particularly because there are messages about who are the people who should be on monkeypox vaccination. And so even for providers who want to broach the conversation, it could be tricky to do. And I think helping folks understand why they think this is important to do without any speculation or judgment about what people do that might put them at increase their exposure to it. I think that's important. And then I think also increasing access. In my example that I offered earlier, even once we got past, I think my provider's initial discomfort with me bringing up the topic of monkeypox vaccination, it turns out I couldn't get it at the place where I was getting my primary care. He told me about the one place in where you could get it, and something I would not have time to do. I had to make time to come to this. So even if my provider had a different interpersonal response, structurally, it wasn't even available in the place where I was going to get it. And it was a limited access point for me to do that. So I think expanding access, there has to be thoughtful ways about how we do that, but there's additional barriers beyond just the patient-provider interaction I think have to be sorted out.
Yeah, that's interesting. And it's something we certainly at PRI, we've discussed, in thinking about the lessons from COVID and we learned certainly the hard way, the importance of not waiting for people to come to you, but go to them, and it might be an opportunity to use organizations or venues where individuals who are at risk likely to be to be at those venues and maybe use the opportunities there to also be able to reach or provide access, like you're saying, Laron. Jeremiah, do you want to add something? Please.
Yeah, I know I'm not the star speakers for this conversation, but just to elevate exactly what you were just saying, Dr. El-Sadr and Dr. Nelson, Dr. Wong, that this is a primary time right now for us to build those structures and those systems to really get vaccine out there. And I was struck by Dr. Nelson, your comment that PrEP users were more likely to be vaccinated. And, you know, just as a shameless plug for something that PrEP for All is really working on right now, we're calling for a national PrEP program. And part of that is to expand the provider network so that we are increasing those touch points. It's not just provider education, which is limited, unfortunately, I think, in its impact, but go where community members already receive services. And if we build that infrastructure, it might help with something like Mpox. So that's something that really comes up for us here at PrEP for All. Just had to plug that real quick.
That's very helpful. Thank you. Another question that I have is that thankfully, as you saw from the epidemic curve, the outbreak curve that you shared with us, Marsha, that we certainly have seen the worst of this outbreak is behind us, hopefully for now. But there have been concerns about resurgence, as you indicated, probably in the summer maybe, as well as the whole issue of endemicity. Of this virus becoming endemic within specific populations, and this kind of the intersection with other sexually transmitted infections. And I'm just wondering, from the perspective of the Department of Health, for example, how are you thinking about the potential for endemicity and or co-endemicity with other sexually transmitted infections in our communities?
Yeah, I have to admit, I'm not entirely sure how to answer that question. I mean, I think there is a sense that it may become endemic and ebb and flow. And, you know, we will have to sort of, you know, ramp up and ramp down our response depending on what's happening. And we struggle with this question as well. I mean, I think, you know, where to even, you know, within, you know, our health department is very large, even where to place the disease in the health department. But I think, as I believe Dr. Daskalakis, at the federal level, you know, I think the move to really kind of think of it as recognizing that there are sort of cases outside of these these certain sexual networks, really sort of pairing it with sort of STI clinics and putting it as part of like regular STI care. Hey, have you gotten your HPV vaccine? Hey, have you gotten your you know, HIV test? Hey, have you got, you know, just making it a part of just regular normal care, I think would really be the goal.
Laron, do you have thoughts on the issue of, I guess it's, you know, this kind of co-occurrence of different kinds of conditions?
Yeah, I again, I agree with what Dr. Wong offered. You know, one of the things I think we could be doing, and this may not be sort of direct clinical responses, but I think in how we study it and disseminate it. I know, for example, the New York Academy of Medicine's Journal of Urban Health tried to be very intentional about the type of research they published on monkeypox. I think learning from the HIV epidemic in terms of what was published when that sort of first began is to invite people to understand what types of systems can be set up to optimize monkeypox coverage for people, both clinical systems, financial systems, community-based responses, and then so that people who consume literature, science, right, can understand that they don't always come up on webinars and they're not always reading MMWRs, but there are other ways that I think there can be a larger multi-level response to normalizing vaccination around monkeypox and destigmatizing messages around it. And I think there's roles for science to do that too. Not just when, I think you see it most when there's an acute epidemic and then they find something else that's more interesting. And I think that's a disservice. And I think we could do a different job, even if this is something that becomes, you know, co-endemic with HIV.
It's interesting that at PRI, we often talk about the the importance of focusing on issues after the acute emergency in these moments between emergencies. And unfortunately, attention shifts away to other things. And while in reality, this is the time to mobilize, is now, to be able to prevent future emergencies, in this case, resurgence of Mpox as one example. Marsha, you had something to add?
Yeah, just really quickly, just a little plug for our public sexual health clinics. If there is anyone who can advocate for more funding, I think they took a hit during the COVID pandemic and were desperately needed, both to deal with sort of, all of the above, HIV, PrEP, as well as Mpox.
Yes.
So as an access point for treatment and care.
And interestingly, I think another lesson we should have learned from COVID is that we haven't done well, whether it be in this country or around the world, in terms of adult vaccinations. We've focused much more and done a much better job at childhood vaccinations, but I think adult vaccinations have been rather neglected, and I think it's important to keep that momentum of COVID-19 vaccination, Mpox, and so on and so forth in terms of preserving health and well-being, like you were saying. I want to just, maybe we have a minute or two, is that do you believe, or do you think one other issue from COVID that we have all noted is the whole threat of misinformation, disinformation? And what can we do as a community to prevent emergence or to suppress misinformation, disinformation about Mpox in particular? Maybe I'll start with you, Laurent.
Thank you. I think this is an investment comment, but I think the way in which federal, state governments distribute resources around information tends to go to academic institutions or big health centers who know a lot less about how to communicate than local, smaller CBOs or groups of people who just sort of get together. And those are who people are listening to. Like, they know how to translate what the issue is, the ways that will be effective. And I just don't think our systems are set up that way. You got to have a registration number of some sort. And I don't know what the barriers are, but they're barriers. And I think we could do a lot better job if we looked at the folks who are doing the work that's limited because they can't do it at scale, and they don't have the resources because they've been shifted to someplace else, who may have reputation from a systems perspective, but not a community perspective. And so the messages that they do get out don't resonate, don't hit. And then so that allows misinformation to proliferate. And so I would advocate for finding ways to do I don't know what you would call it, non-traditional organizations or groups who are the people who can get the message out the way it needs to be disseminated.
Marsha, do you have something to add to that?
Sure. Yeah, I agree with everything Dr. Nelson mentioned. I think this whole leading with a grassroots CBO type of response and doing it early to try to get ahead of the misinformation. I don't think we did that well with COVID. I don't think we did that well with Mpox from a health department perspective, but I think there is some advocacy within the health department to try to really do this for the next response, to really start with the grassroots level, which we do have connections to, but sort of we're not really can be lost or not prioritized in the midst of the beginning of the response, but it needs to be the first part of the response, I think. Even if we don't have complete scientific information, I think we need to trust people with the nuance that we don't know.
That's extremely helpful. And certainly at PRI, we do have one of our pillars is a communication pillar and the community pillar. And there's certainly the groups that are involved in these two spaces are very much committed to bringing community voices and changing the nature of messaging and the messengers and so on. And it's great to work on this in partnership with the CUNY School of Public Health as well, and with the Department of Health here in New York City. And I think the time is now to be able to work hard on crafting those messengers, identifying the trusted messengers and so on and so forth. So thank you. Unfortunately, we've exhausted our allotted time today, but I want to thank you all for being with us today, all of the people attending this webinar, our speakers in particular. Thank you for the partnership with Prep for All. Thank you, Jeremiah, for your partnership. And I think the messaging from today is very clear, is that we have to continue to overcome the barriers and the challenges that Dr. Nelson mentioned, and to think about the threat of Mpox to communities at risk, and particularly for people at risk for HIV and people living with HIV. Thank you all, and have a good day. All the best.